Okay, good morning, everyone. My name is Yana Gordeyeva. I'm a graduate of Poznan University of Medical Sciences, and today I will be presenting on Essential Tremor and Essential Tremor Plus. Now, briefly going over the content of this presentation. So I'm going to start with an introduction, then I'll go over a case, the etiology of essential tremor, exclusion criteria, presentation, differential, then I'll briefly go over the definition of essential tremor plus, association between essential tremor and Parkinson's disease, and finally the workup and management. Okay, so what is essential tremor? So it is considered to be one of the most common movement disorders. It is defined as an isolated tremor syndrome. So in other words, it's an involuntary rhythmic shaking involving both upper limbs during action for a minimum time frame of 3 years, with or without tremor in other body segments. And these other body segments could include the head, the voice, and the lower limbs. And the prevalence of essential tremor in the US is estimated to be between 0.3 to 5.6% in the general population. It's more common among people older than 65, but it can affect people at any age. And studies suggest a bimodal age of onset. So we see it start in those younger than 25 and late onset greater than 65. The young onset essential tremor is more often characterized by a positive family history and a response to alcohol. And the late onset essential tremor is linked to a greater frequency of cognitive impairment or dementia. And the case we have here is a 67-year-old right-handed female who was referred for management of essential tremor. And so she's had already a history of essential tremor since junior high school and involved bilateral hands with the left hand tremor greater than the right. And so she stated the tremor progressed over the past 7 years. It was exacerbated with voluntary movement. For example, she had difficulty holding objects such as bringing a glass to her lips and putting on makeup. She also stated that her handwriting had become completely illegible. Along with the bilateral hand tremor, she also had an associated bilateral leg tremor. It was previously only present during times of stress, but had become constant over the past 2 years. And she did note the tremor improved with alcohol, but she rarely drank. She did use propranolol in junior high school to treat the tremor. However, it was stopped due to hypotension, and she hasn't been on any medication since then. She also knows the tremor is exacerbated by stress. In terms of medication, the only things she's taking are medications to treat osteoporosis, some vitamins, and alprazolam as needed for insomnia. She also has some ventricular premature beats. Her family history is significant for essential tremor in her brother and her father. And on physical exam, you could see the bilateral hand tremor, and we saw that the left was the greater than the right, and a bilateral lower extremity tremor that we both saw on limb extension, and it was also visible at rest. She also had an abnormal spiral drawing test, as you can see here. You could see a slight tremor here in the right hand, but the left hand we could see is much worse. She did have some imaging done. She had an EEG and CT head, which were both normal. And then she was started on Primidone, 250 milligrams, half tablet. On a follow-up 2 weeks later, she did report marked improvement in her bilateral hand tremor and disappearance of bilateral leg tremor. She said she was finally able to put on makeup without any trouble, and her writing had significantly improved. Okay, so we don't really know the etiology of essential tremor. We do know that it's familial in about 50 to 70% of cases, and the transmission is autosomal dominant. In some cases are sporadic. There is a hypothesis, the GABA hypothesis, for the pathophysiology of tremor. And basically this hypothesis states that there are two areas of the brain, the cerebellum and the thalamus, that give rise to these tremors. And the cerebellum is rich in Purkinje cells that manufacture and release GABA, which we know is an inhibitory neurotransmitter, and they're particularly responsible for regulating and controlling motor movements. And this hypothesis suggests 4 steps that lead to the development of tremor. So there, in the first step, there's the Purkinje cells begin to degenerate, less GABA is produced, and there is decrease in the cerebellar GABA system's activity involving deep cerebellar neurons. Now, these deep cerebellar neurons act as pacemakers, and without the GABA inhibiting them, the pacemaker activity increases. And this in turn affects the thalamus and the rhythmic activity causing the tremor. And there are some exclusion criteria for diagnosis of essential tremor, and these include abnormal neurologic signs such as dystonia or an abnormal muscle contraction that leads to an abnormal posture, ataxia, Parkinson symptoms such as rigidity and bradykinesia. And also, there should be no presence of known causes of an enhanced physiologic tremor. So we all, as healthy individuals, have a physiologic tremor, but it can be enhanced with anxiety, with stress, and also with recent exposure or withdrawal from certain medications. And some of these medications include things like SSRIs like fluoxetine, amphetamines, caffeine, iodorone, beta-adrenergic agonists like albuterol can also enhance tremor. And also withdrawal from alcohol or benzodiazepines. And we also there should be no evidence of a psychogenic tremor. The thing to know about psychogenic tremors is that they're very abrupt in onset. They have a highly variable amplitude, frequency, direction. They're very intermittent and inconsistent. And they're also characterized by distractibility. So if you can find a way to distract the patient, you can either lessen or abolish the tremor. And essential tremor is a gradual progression. So there should be no sudden onset or stepwise deterioration, which would be suggestive of other disorders. And primary orthostatic tremor, it is characterized by tremor in the legs that occurs when standing and disappears when the patient either walks or sits. And there should also be no isolated tremor. So remember, to diagnose essential tremor, you need that bilateral upper extremity involvement with or without tremor in other body segments. So there can't be just an isolated voice tremor, isolated tongue, chin, or leg, or any isolated task-specific tremors, for instance, a primary writing tremor. And here I have, I already went over some of the medications that can exacerbate tremor, but other medications include haloperidol, an antipsychotic, verapamil, valproic acid, among others. Okay, and I'm going to discuss the presentation of essential tremor. We already discussed there's usually a family history in greater than 50% of cases. It is a gradual, insidious onset and progression of tremor. And the tremor usually begins in one upper extremity and then affects the other. And asymmetry in the tremor is not unusual. As we saw in the case presentation, the patient had a left-sided tremor that was worse than the right. And the tremor can involve the head, most commonly in the voice, jaw, and face. And head tremor is most common in women and can dissipate when the patient is supine. Jaw tremor is most prominent when the person is talking, and it should not be present at rest. So in Parkinson's disease, there can actually be a jaw tremor at rest that disappears with talking. So that can be one way to distinguish a Parkinson's tremor and an essential tremor. And the tremors usually start intermittent initially and can emerge only during periods of emotional activation, such as stress or anxiety, hunger, fatigue, temperature extremes. And then it becomes persistent over time. And the amplitude of the tremor can vary depending on the state of emotional activation. And it usually increases over several years. It can also resolve during sleep, and in many patients, alcohol can temporarily reduce the tremor. And then patients of older age have a more rapid disease course and can have associated some cognitive impairments, specifically impairments of attention and working memory. And here are some examples of the tremor that we can see on physical exam. Now, the rest tremor is what we typically associate with Parkinson's disease. But can you see a resting tremor in essential tremor? And the answer is yes, especially after many years of essential tremor and an increased age in the patient. And about 30% of patients present with resting tremor. And the action tremor, that's the one we commonly see essential tremor. And it can be postural, meaning that when a person maintains a position against gravity, such as holding the arms outstretched. Kinetic tremor, that's associated with any sort of voluntary movement, such as moving the wrists up and down or opening the eyes. An intentional tremor is with any targeted movement, as you see with the finger to nose test. And this is just repeating. So tremor, characteristically postural or kinetic and essential tremor resolves when the body part relaxes. Both upper extremities are typically affected, and you should see normal tone and reflexes on the exam with no Parkinsonian features such as bradykinesia or rigidity. And there are some bedside tests you can do to help be able to visualize and distinguish the tremor, including asking the patient to extend their arms, to perform finger to nose movements, spiral drawing. And here we have an example of that. This is a normal spiral. This is a Parkinson's disease spiral. And you can see the micrographia or the small handwriting that's typical of Parkinson's. And here we have the essential tremor. Then you can also ask the patient to pour water, drink water, and use a spoon. And here I have some examples. Hopefully you can see. Here we have that bilateral hand tremor, and as you can see, the right side is worse than the left, and so you have that common asymmetry between the tremors. Here we have a patient with a head tremor, and I'll play it again so you can see. And here is an example of intentional tremor. You could see this lady trying to bring the spoon to her mouth, and she's having difficulty, and that's a targeted movement. And here is another example of intentional tremor, the finger to nose test, and we can see the tremor get worse as he's bringing the finger to the nose. And I also have a video that will show these bedside tests. Will work. Okay.
This patient has a bibrachial action tremor. He was diagnosed with essential tremor at the time of this video and was not taking any medication for the symptom. These videos show the no-no neck tremor that is present with phonation. The neck tremor is never present at rest. Voice tremor is present even when the head is held.
Oh, and just to explain, when he's saying a no-no tremor, that's a tremor present when we're making the no-no and yes-yes movements with the head.
The patient is asked to sustain vowel sounds to detect the presence or absence of a voice tremor.
The rainbow is a division of white. light into many beautiful colors. These take the shape of a long round arc with its path high above and its two ends apparently beyond the horizon.
For as long as you can. Good. And then I want you to try to do the same thing with E.
E.
This woman has a slowly progressing action tremor in both arms, starting over 30 years prior to the video. She was only taking low-dose propranolol at the time of this initial assessment. Higher doses made her sleepy. By having patients pour water or try to drink water, the examiner can better assess the extent of the disability. The spiral is another test the examiner can use to assess tremor. She has asymmetry in her symptoms and has an intention tremor that is present when she attempts to put the pen onto paper. Smaller spirals will be more challenging as the target is smaller.
Okay, so we can see that the tremor can be quite disabling for the patients. And a disability from essential tremor is quite common. So greater than 85% of patients report significant changes in their livelihood and socializing. It's mostly due to loss of function and embarrassment, especially patients who have a voice tremor. And they have to do presentations as part of their work. And many do either retire or change jobs. Some of them embarrassed to dine out or attend parties because of the tremor. And that's just something to be aware of and empathize with the patient. Okay, and so differential diagnosis of essential tremors, we discussed before, we want to rule out any sort of enhanced physiologic tremor. So we want to evaluate for any anxiety, any caffeine use, any sort of medications that were recently started that could have caused the tremor. And also we want to rule out any sort of metabolic disorders by looking at thyroid hormone, liver function, glucose levels, kidney function. Already discussed psychogenic tremor, and also can rule out isolated tremor. And then the essential tremor plus in Parkinson's disease, I'm going to discuss in more detail in later slides. And then Parkinson plus syndromes, they also can present with tremors, not as commonly as in Parkinson's disease. Wilson disease can also present with tremor. That's the inherited disorder of copper metabolism, characterized by excessive copper deposition in the liver, brain, and other tissues. And multiple sclerosis can present with tremors as well. Okay, and so Essential Tremor Plus syndrome, or ET plus. So in 2018, the Movement Disorders Society decided to come up with a new term called Essential Tremor Plus, and it's relatively a controversial term, and I'll discuss why in a little bit. But it is defined as a tremor with all the characteristics of essential tremor and additional neurological signs of uncertain significance that don't suffice to make an additional syndrome classification or diagnosis. So what do they mean by these additional neurological signs of a certain significance? So what they're trying to describe are subtle neurologic signs or soft neurologic signs, and the examples they give are impaired tandem gait, questionable dystonic posturing, any cognitive impairment or a resting tremor. So for instance, a patient who has essential tremor and as well as develops a resting tremor, they want that characterized as an ET plus syndrome. And you could see where the controversy lies in that, because they have no clear definitions as to what they mean by questionable dystonic posturing, or how impaired does the tandem gait have to be for it to be uncertain significance. And in patients who do have a resting tremor as well, we do know that in essential tremor later on in the disease and with age, they can present with a resting tremor. So there's just a lot of debate and confusion as to what they mean by these additional neurological signs. And there's also really no underlying biological basis for ET+, and it's solely based on clinical grounds. So there's no pathology, there's no etiology, there's really no difference in the prognosis with ET+. And then ET and Parkinson's disease. So they did a study. They found that a subset of patients who developed Parkinson's disease after essential tremor, or found to have Parkinson's disease along with essential tremor. And so in this study of over 600 patients, they found that 6% of essential tremor patients were found to have PD, and another study about 20% were noted to have a coexistent PD. And they can't, so not really saying that essential tremor causes Parkinson's disease in any way. There's really no conclusive evidence to suggest that. They have found, or some studies suggest that long-term treatment with propranolol or any beta-2 adrenergic antagonist for a long time can perhaps increase the alpha-synuclein so that the toxic protein implicated in the pathogenesis of Parkinson's disease, but that's still being studied. And they found some distinct features in these patients who had both essential tremor and Parkinson's disease. So they found that it was a tremor dominant subtype of Parkinson's disease. So the resting tremor was very prominent. And there were usually a long duration of the tremor before the onset of Parkinsonism. And the mean latency of essential tremor to the first sign of Parkinson's was about 14 plus or minus 15 years. So let's say the mean onset of ET was about 52 years old, and then they go on to develop the first clinical symptom of Parkinson's at age around 66. And furthermore, these patients usually had presence of cerebellar signs such as gait abnormality, like a slow steppage gait or a small steppage gait. There was usually a slower progression of Parkinson's, and they also exhibited a strong family history of essential tremor. Here's a timeline in someone who developed Parkinson's disease with essential tremor. So after 3 years, for instance, you have a patient who was diagnosed with essential tremor. Let's say they had essential tremor for about 18 years. And then they go on to develop some not completely clear Parkinsonian signs, but for instance, maybe they have a slightly stooped posture. They do have a resting tremor, but it's not clear whether the resting tremor is it as a result of the Parkinson's, or maybe after having many, many years of the essential tremor itself. Or maybe they have a small steppage gait, but it's really not enough to diagnose Parkinson's disease at the time. So they do is call it an ET+. And I'm gonna, in the next slides, I'm gonna discuss a way to actually be able to confirm Parkinson's disease in a patient with essential tremor. Okay, and so for the workup for essential tremor, so it's usually diagnosed clinically and by family history, but if it's not really clear, you can order laboratory testing and imaging. And again, we're gonna look for any metabolic disturbances. We're gonna look for thyroid function tests because hyperthyroidism can present with a tremor. We're gonna look at liver function, standard electrolyte panel, BUN, creatinine, serum ceruloplasmin to check for Wilson's disease. And then imaging. So CT MRIs are usually normal in essential tremor. If the tremor has an acute onset or a stepwise progression, then we really want to perform an MRI to rule out any sort of structural or inflammatory lesions such as MS or Wilson's disease. And the DAT scan, I think it's one of the most important tests in being able to distinguish essential tremor and Parkinson's disease, because the DAT scan, the dopamine active transfer scan, it can tell us whether there has been a loss of dopaminergic neurons. And this scan involves the injection of a radioactive agent that binds to dopamine transporters in the brain. And it has about a 90% sensitivity and specificity for Parkinson's disease. And here you can see what it looks like. So this is a normal DAT scan, and you can see these comma shaped areas here with normal dopamine binding. And you can see it's also normal in drug-induced Parkinsonism as well as essential tremor. Now in Parkinson's disease, we can really see the loss in dopamine density here. The only thing this DAT scan can't distinguish is between Parkinson's disease and other Parkinson plus syndromes such as MSA or PSP. And this test, if not, the only downside is if this test isn't covered by insurance, I think it's about $2,500 to $5,000. There is, however, another test that they found that can help distinguish between Parkinson's disease and essential tremor. And they're saying that has a diagnostic accuracy of 90%. And this is the Tremor Stability Index. So what they do is use a device that they attach to the hands to be able to measure the tremor. And here's just an example of device. It's connected to the iPhone, and you attach it to the wrist or index fingers and middle fingers. And they take 10 seconds recording of this tremor. And there is, and what they're doing is measuring the frequency distribution of the tremors. And for a tremor stability value of greater than 1, it's likely to be essential tremor, and less than 1 is more indicative of Parkinson's disease. And it's short, it's a short test, it's cheap, and widely available. And this is just an example of what the test will show. So here we have Parkinson's disease. We can see that it presents a more narrow and sharper frequency distribution. And here we have essential tremor. It's a bit more broad. Okay, and next I would like to discuss the management of essential tremor. And we're going to divide that into pharmacologic, non-pharmacologic, and surgical. So for pharmacologic management, propranolol and Primidone remain the first line oral drugs for the treatment of essential tremor. And we can see a response to these medications in about 2/3 of patients. Primidone is usually started in older patients as propranolol, usually in younger patients, because propranolol has more serious adverse effects in older people, especially those with comorbidities, and they're on other medications to treat hypertension and heart disease. And they both have the same amount of efficacy. Second line drugs include topiramate as the one that's most commonly used. Thing to note, there can be a high dropout rate due to cognitive side effects and somnolence that's associated with this medication. Another thing to ask patients if you're prescribing topiramate is if they have any history of kidney stones, because this can increase the risk. And then we have medications such as gabapentin, zonisamide, and anticonvulsant, but these aren't used as commonly. Clozapine, there's risk of granulocytosis, mirtazapine, and benzodiazepines we generally want to avoid due to the addictive potential. And there's also botulism toxin, which can be used to treat head tremors, however, is not as effective in treating the hand tremors. And then, yes, patients do notice that the tremors can improve with alcohol, but that's not something we want them to take on a maintenance basis. There's some studies showing that maybe in a very intermittent tremor, they can use alcohol, like such as attending a meeting or engaging in a social activity. However, there's of course alternative is propranolol, about 10 to 40 milligrams that they can use a half hour prior to the event. Okay, and the surgical options are for patients with a disabling medically refractive upper extremity tremor, so refractive to any of the pharmacologic medications. And these include stereotactic thalamotomy, deep brain stimulation, which I will discuss in more detail in the next slide. And then bilateral thalamotomy is not something we really use anymore due to the high risk of adverse events such as high risk of dysarthria, difficulty speaking, and the risk of cerebral hemorrhage. There is a new machine, the MRI guided focused ultrasound thalamotomy, that's proven to be pretty effective. It's not as invasive as these other surgeries. This is a picture of it. So basically, they do is they use an MRI machine, and then they direct over 1,000 beams of ultrasound to a specific target on the body. And in this case, it's going to be the thalamus. And so these beams then raise the temperature of the targeted spot of tissue and then destroy that tissue. The side effects of this can include some numbness, tingling of fingers, imbalance and steadiness, maybe some loss of control of body movements. But patients do typically report a 40% improvement in their hand tremor that lasts up to, and they can be seen up to after 1 year. Okay, so thalamotomy versus deep brain stimulation. So stereotactic thalamotomy, they are drilling a hole in the skull and then inserting probes that damage the targeted thalamic nucleus, specifically the ventralis intermedius nucleus. And different methods can be used to kill the brain cells, including inserting circulating liquid nitrogen into the probe, or by inserting an electrode heated to about 200 degrees Fahrenheit to denature the cells. And this surgery is less expensive than deep brain stimulation. I did look up the prices. It says it's about $15,000 for a stereotactic thalamotomy, while a deep brain stimulation would be around $22,000. It's still expensive, but less expensive than the DBS. The advantage of this surgery is there's no hardware in the brain. You just put in the probe, destroy the thalamus, and then take the probe out. And then there's about 80% improvement in essential tremor with continued beneficial effects for up to 5 years. The side effects include intracerebral hemorrhage, motor weakness, dystonia, speech disturbance, and memory loss. In some cases, they have described motor weakness and speech disturbance to be permanent, which is one disadvantage of this surgery. And then in deep brain stimulation, they're implanting a thin insulated coiled wire, each ending with an electrode that delivers signals to stimulate the targeted areas in the thalamus. And the amount of stimulation is controlled by this pacemaker device that's placed under the skin in the upper chest. And patients typically report a 60 improvement in the hand tremor following the first surgery. So the main advantage of this surgery is that it's adjustable. You're not doing any permanent damage to the thalamus, and any adverse effects from the stimulation can be controlled by just reducing the stimulation. And side effects include hematomas, some malfunction of the implantable pulse generator, and it typically needs to be replaced. This pacemaker needs to be replaced usually after 15 years. And there can be also the risk of some postoperative seizures. Finally, I'd like to discuss non-pharmacologic management, and there are so many different assisted devices that can help with essential tremor. And I posted a link to a website that goes over all these devices. And they include things like spoons with stabilizing handles, orthostatic devices that provide resistance to the tremor, and also surface stimulation devices that disrupt the central tremor network in the brain that causes the hand tremor. Here are my references, and that's it for my presentation. Thank you all for your attention.